Good afternoon or good morning to you, depending on where you are, what state are you in. My name is Dr. Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Thank you for joining us and attending our session number 2 of this learning collaborative, expanding diabetes prevention and management through health center outreach. Um, if this is the first time that you are attending this learning collaborative, thank you for joining us. We are the National Center for Health and Public Housing, and we are conducting a series of 4 sessions on diabetes prevention. We're focusing on community healthcare workers and the role that community healthcare workers have in diabetes prevention. Some housekeeping items. At this moment, all participants are muted. So since this is a very small group, we only have a few participants. If you don't mind, and if you have access to your camera, you can turn your camera on so we can have a very interactive session. At the same time, you can engage in the chat. Any questions that you have, you can type it in the chat box and we will try to respond to all your questions. If you would like to speak, make comments, you can use the raise hand icon and your line will be unmuted. At this moment, the meeting is being recorded, and the slides, the recording, and the resources will be sent to all participants via email within a week after this session. Next slide. You can access the material as well on Moodle. You need to go to moodle.nchph.org and select this learning collaborative, expanding diabetes prevention and management. If you don't have an account, the application will ask you to create an account first, and once you have your username and password, then you will be able to access all the resources that we are sharing through these learning collaborative and the 4 sessions that we are planning to discuss. Also, we have a welcome packet with information about learning objectives and the content for each of the sessions that we are developing. So Moodle is another tool that you can use to engage, ask questions, share best practices or challenges that you have. This is a very good way to communicate with other participants as well. Next slide. Quickly, for those who are just joining us, and this is the first session. Again, we are the National Center for Health and Public Housing, and we provide training and technical assistance to community health centers. We specialize in health centers located close to public housing developments. However, as you know, the diabetes issues and the diabetes challenges are about the same for all the special populations. So at this moment, we are trying to reach out to all health centers across the nation. We are supported by HRSA to provide training and technical assistance, and the content of the learning collaborative and everything that we are sharing do not necessarily represent the official views of HRSA. Next slide. This is only for new registrants. If by any reason you couldn't attend our first session, and if this is your first time, in the chat, please type your name, your role, the health center name, and where you are located, or what state you are located. Okay, we're going to give like a minute for those who are just joining us for the first time. Right, so it seems that all attendees right now were able to participate. Let's see, we do have some chat, some responses in the chat today. So we have Cindy Artero and Jennifer Martinez. CCI Health and Wellness Services. Thank you for joining us. We also have Jennifer. We have Diana Chavez with Diabetes Program Coordinator at the Health Choice Network. Thank you, Diana, for being with us. Then we have Carolina Velasquez. She is with CCI Health and Wellness Services. Thank you so much for being with us. And we have Lynn Olmsted. Thank you for being with us as well. CHW at Grace Health Battle Creek in Michigan. So thank you for taking the time to share with us your location, your health center, and your title. Next slide. Just a quick overview, and this is a map that the National Center for Health and Public Housing has developed with information on health centers, specifically all the clinical sites and those health centers located in or immediately accessible to public housing. Sorry? So those health centers located in immediately accessible or who are immediately accessible to public housing, in 2019 we had 433 and they served over 5 million patients. Out of the 433, 108 are receiving funding from HRSA to provide services to public housing residents. And in 2019, based on the latest UDS data, they served over 100,000 patients. Next slide. This I like this slide because diabetes, as any other chronic medical condition, is tied to social determinants of health and demographics. We've been conducting different sessions with different groups, including the National Training and Technical Assistant Diabetes Task Force. We've been discussing social determinants of health in general, on health literacy, and the challenges by population. So I would like to mention some highlights. 45 or 43% of those living in public housing are African American. 25% of them are Hispanic. 35% of those living in public housing are over the age of 65, and 38% of households report to have at least one person with a disability. 55% of those living in public housing have less than a high school diploma, which is another social determinants of health, which is tied to diabetes and how patients understand diabetes, which is a very important topic, and where a topic that CHWs can address with the population that they serve, since regardless of the diabetes management or the pre-diabetes or anything that is related to diabetes, such as exercise and nutrition, even if they receive that information from the providers, it's always necessary to reinforce the information, and that's one of the roles that we are planning to discuss today. As a CHW, you can reinforce whether the patients are understanding the instructions, any prescription that they receive from the doctor, based on that, provide the education or refer the patient back to the health center to make sure that the patients are compliant with all the recommendations that they receive from the clinical staff. Next slide. In general, there are almost over 2.7 million patients with diabetes. That represents 9% of the population receiving services at health center sites. And in public housing, 9.6% of them have diabetes, which is a little bit more than 82,000 patients with diabetes in public housing developments, or at least those living close to public housing. Next slide. So we are going to review some evidence, and these are evidence-based for embracing CHWs into the public health and healthcare. This is, we are not trying to say something that is not research-based. This is what we are going to discuss is something that have been addressed by some organizations, and specifically research organizations, on how what the role of CHWs, or the role that CHWs can play in diabetes prevention, which is extremely important. This is not only what the NCHPH or the National Center for Health and Public Housing is saying, but we are backing the role that you as a CHW can play with research and recommendation from agencies that have dedicated time and resources to provide this information. Next slide. So today we are going to discuss 3 learning objectives. We are going to summarize the Community Preventive Task Force recommendation for interventions using community healthcare workers. We are going to explain the roles and competencies that CHWs can play in diabetes prevention, and we're going to briefly discuss action steps to capture the contribution of CHWs in clinical settings or clinical sites. Next slide. So every time that we talk about CHWs, and when someone is not familiar with the role of CHWs, they have four questions. One is, who are CHWs? What do they do? We've been discussing diabetes for many years because diabetes is one of the HRSA's priorities. And I have had the opportunity to talk to private organizations, even the Agency of Housing and Urban Development. And sometimes they do not have a very good understanding of CHWs and the role that CHWs play. As I mentioned, the first time that we met, I've been part of the American Diabetes Association advisory group. And one of my roles is just to bring to these organization the role of CHW, the role of the health center role, what they are doing for these special populations and for the low-income populations and for the underserved populations in the United States. So one of my roles when I have these conversations and these meetings is explain to them the role of CHWs, what they do, where they work, and what some of the milestones that they do, and how they work together with the clinical staff and non-clinical staff to make sure that the patients receive a holistic approach, and we address not only the clinical needs, but also addressing the social determinants of health and other needs that they have in the community. Next slide. I like case studies in particular. I feel that this is a really good way to learn. This is something that you do every day. You have contact with your patients in the community or with the population that you serve. So we are going to briefly discuss this case study at the end. We are going to talk about AB, who is a retired 69-year-old man with a 5-year history of type 2 diabetes. The patient was diagnosed with diabetes in 2013, and he had symptoms indicating hyperglycemia for 2 years before diagnosis. He had fasting blood glucose records indicating values of 118 to 127 milligrams per deciliter, which were described to him as indicative of borderline diabetes. And borderline diabetes is quoted there. So we are going to discuss that. He also remembered past episodes of nocturia associated with large pasta meal and Italian pastries. At the time of initial diagnosis, he was advised to lose weight at least 10 pounds, but no further action was taken. The patient was referred by a nurse to the health center with recent weight gain, suboptimal diabetes control, and foot pain. He's been trying to lose weight and increase his exercise for the past 6 months, without success. So just keep this gentleman in mind. So we are going to get back to this case study after this brief presentation. Next slide. So as I was mentioning, my role as the Chief Medical Officer, one of my roles as the Chief Medical Officer for the National Center for Health and Public Housing is to bring to some organizations information about the role of CHWs and the clinical and non-clinical staff working for community health centers. And this slide explains specifically the discussion that we have had with other organizations. And CHWs are basically those providing education and addressing the social needs of patients or low-income patients in the community. And they are the link between the clinical care or the health center with the community. There is sometimes, I feel that sometimes we work in silos. We have clinical staff providing all the clinical services to patients, but we do very little to address the public health concerns and what the patient and the patient's needs in the community. And that's where the CHWs are the best liaison for the health centers and the community. So they are trusted by the community. They know the main concerns, the main challenges, and they bring that information to the clinical staff. So there is an interaction, and again, a holistic approach to serve patients. It's not only dealing with nutrition or exercise programs, but what is behind those needs, why patients do not exercise, why patients are not having proper nutrition. And that's the information that CHWs provide to the clinic. That's the information that is the information that the clinical care team needs to better understand the social and demographic needs of the patient so they can provide the best services, healthcare services and prevention services to the patients. Next slide. So basically, CHWs possess the 3 C's of the community: connectedness, credibility, and commitment. You as a CHW are the link to the community. You are a credible person, someone who can interact with patients and have the ability to speak the same language because you understand the challenges and the needs of the community, and you have the commitment to serve your community. Recently, we had a conversation about COVID-19. Last week, for instance, we had the opportunity to discuss COVID-19 vaccine hesitancy. We had conversations with public housing leaders in regards to why people living in public housing do not want to receive the vaccine. And we had a very nice conversation about what they thought were the main concerns and causes why those living in public housing are hesitant to receive the vaccine. And the good outcome of this conversation was the ability that they have as leaders to go back to the community and say and debunk some of the myths and challenges to get the vaccine. If they receive the right information, they will be able to provide the right information to those who don't want to receive the COVID-19 vaccine at this moment. So it's the same with other conditions like that, such as diabetes. I mean, once the CHW has a very good understanding of diabetes, has a very good understanding on prevention, then they can provide that information to the patient. But at the same time, they can bring all the challenges from the patients to the health center. So there is an interaction and some type of synergy to better address diabetes in the community. I'm going to stop for a moment. Peter, it seems that there is a comment in the chat.
Yep, that is correct. So we have Ain Saini from Elica Health Centers in Sacramento, California, saying that I guess they need to explain the patients what kind of exercise is better, aerobic or anaerobic, rather than just saying you need to exercise.
Thank you for that question. That's a really good question. And there is a combination, I mean, patient, and it will depend on the age of the patient as well. But the idea is to make sure that the patient understand that the calories that they gain are the calories that they have to lose. And in order to do that, they have to have aerobic exercises. But at the same time, depending on the age of the patient, as we age, we tend to lose muscle as well. So an aerobic exercise or weightlifting or some kind of exercise improving the body mass, of these patients are crucial. So the recommendations that we get from agencies such as CDC is aerobic exercise. However, it's in my opinion, we need to offer patient both aerobic and anaerobic exercise programs, because we are making sure that the patient not only get do not only address diabetes but other conditions. Patients tend to have other conditions such as osteoarthritis, for instance, or arthritis or osteoporosis. So we are making sure that by offering or advising patients to get aerobic and anaerobic exercises or being these kind of programs where you are addressing not only diabetes but other conditions. Next slide. So CHW definition, I feel that I'm gonna preach to the choir here. You know what you do, you know how you do it better than me, but this is from the American Public Health Association, and this is the definition that is used by most of the federal agencies as well as other nonprofit organizations in regards to CHW. They define CSWs as the frontline public health worker who are trusted members of the community, and they have close understanding of the community they serve. They have trusted relationships, and this trusted relationship enables the CSW to serve as a liaison between the social services and health services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. And in regards to diabetes, I would like to stop for a moment and, based on the definition, see what is your role. This is very important for all of us, and learn what your role is when you have patients with diabetes in the community and what kind of services you offer. You can either unmute, use the unmute icon, or just type your response in the chat box, and it would be nice to hear from you based on the CHW definition, what you do and what is your role when you have patients with diabetes. I'm going to stop for a moment, probably a minute.
Hi, everyone.
Hi, Jennifer.
I'm here. Yes, you can call me Jenny. So I'm here with Cindy. What we've come across here with the clinic with our diabetic patients, we do have a population of patients that don't have legal status. So when it comes to helping them, with get medications and things like that, we understand sometimes diabetic medications can be very costly. So what we do is we try to find online patient assistant programs where we can try to apply so that they can receive some of these medications for free for up to a whole year. And we try to set that up. We fill out the application and we will work collaboratively with the provider to make sure we can get the information of what kind of medications that the patients need. And we also have the patients fill out their portion of, if they are Maryland residents, if they live here in the United States. That way we can see if they are eligible in order to receive this medication for free. So that's one thing that we sort of help with our patients with the main barrier of not being able to pay for diabetes medications. We look for programs where they can get those medications for free and sometimes even delivered to their homes, or they can come pick it up here at the clinic.
Thank you, Jenny. That's really interesting and very useful for your patients. What organizations, either in the community, do you reach out to provide those services to your patients? For instance, do you reach out to pharmaceutical companies, or what organization do you reach out to?
So the way we have it set up, we have, not that we've reached out to them, but we have a whole bunch of resources, like from Johnson & Johnson is an example for the medications. We also use the pharmaceutical company through Sanofi. We also use, what was that?
Lilly Cares Foundation.
The Lilly Cares Foundation. So we have like a sort of like a handbook of all of the applications and the type of medications like insulin or anything like that. And we sort of fill out the applications. If anything, our best friend is Google too.
That's really nice. And the last question I have for you is, what population do you serve? Is my understanding that we are talking in general about low-income populations, but do you have like public housing residents or people experiencing homelessness or migrant and agricultural workers?
Yes, so from time to time, so here, because CCI has a variety of clinics throughout 2 counties, Montgomery County and PG County. So we have, a vast population, of homelessness, if anything with mental health, with undocumented immigrants or anyone who has are underinsured. So we have like a variety of patients that we serve, even if they are also in housing as well, with housing assistance as well.
Thank you, Jenny, for that. And just to let you know, the National Center is very close to where you are. So I'm going to probably touch base with you offline to have a more deep discussion on this particular issue. But thank you for your feedback and for providing that information to all participants. Thank you, Jenny. And Fide, we have somebody who typed something in the chat box. Is that correct?
That is correct. So we have Lynn Olmsted, and she is from Grace Health in Battle Creek. And she says, we do eligibility enrollment to see if patients will qualify for the food pharmacy program, and we cover urgent medications and get them help to enroll in a health plan.
Great, thank you so much. And we've been discussing community collaborations as well. We are going to discuss during our next session nutrition and resources for patients, specifically for those in areas where it's difficult for them to get healthy food. So this is extremely useful. Thank you so much for sharing that information as well.
Okay, and then we also have another one from Belliana Watts McGilbury. And she says, we refer to registered dietitian, offer compassionate care program for meds, encourage food stamps, local churches, or food banks for food assistance, utilize our homeless clinic and mental health services as well.
Excellent, thank you so much. And this is exactly the type of information that we are looking for. Honestly, at the same time that we provide this training to health centers, we get the feedback and the information that you provide and discuss with other agencies. So these agencies can develop materials for CHWs. So the more information that you provide, the better for us. And we will appreciate any comments or challenges or resources that you have in mind. So every time that we have conversation, either with the Center for Disease Control and Prevention or the American Diabetes Association, we bring these comments, these challenges, these resources, so they're able to to offer additional resources or additional training. So thank you so much for sharing all this information. It's very useful. Next slide, Fide. So again, CHWs have different names, promotores or promotores de salud, peer leaders, outreach educators, community health advisor, home visitors, street outreach workers, and they provide, you provide all kind of services. You're an advocate, you are serve as a patient navigator, or the peer advocate, or sometimes you are the link with your community and the coordinator with the community. Provide or you are the representative. Based on what I was explaining briefly, we've been in contact with public housing leaders, for instance, and we've been discussing COVID-19 vaccine challenges and COVID-19 vaccine hesitancy. And you are the best point of contact to make sure that the patient receive the right information at the right time. Is there any other comment in the chat?
Yes, so we have from Diana Chavez. She says, do you know of any organizations that provide support to community health centers in the implementation of a DSMES program at a low or no cost?
That is a very good question, Diana. Is my understanding that the American Diabetes Association provides some help and support. I will double check with you, and then I'm gonna get back to you if it's my understanding, Fida, that we have her contact information, so we can put her in contact with any of the ADA members. But this is for diabetes management and education support programs. So that's something that we are going to do and see whether this is something that they can help you with. So CHWs, again, offer all kind of resources. And again, I am very humbled to say that you better than me can explain all the good services that you offer. But basically it's outreach, I'm sorry, and provide services and explain patients the services that you have and link patient with resources in the community or pharmaceutical companies that we discussed, and offer some options to patients, low-income patients, many of whom are either underinsured or do not have any insurance. So that's one of the issues, as well as creating a confidence with patients. We are going to briefly discuss as well the migrant population, and somehow they need to trust someone to receive health services in the community. So next slide, Peter. So CHW are experts. They serve as navigators, chronic disease managers, benefit experts, health educators, and counselors. So you wear different hats. Sometimes you have to, based on the limitation that health centers have, and some of them are understaffed, you have to wear different hats and just to make sure that patients receive all the preventive services that they need and the resources that they need in the community. Next slide, Peter. Again, the CHW roles, which is important here, is to discuss the implementing individual and community assessments. Another important role, as we are going to discuss briefly in the next slides, and the outreach and the participating in evaluation and research, which is another topic area, an emerging topic area. Many organizations are right now working with low-income populations and those special populations, trying to get a better understanding of the healthcare needs and how the social determinants of health are linked to some of these conditions, such as diabetes. And they are conducting a series of research studies aimed at getting a better understanding of the social needs of your patients. So this is another big topic area where CHWs can play a big role and serve as the liaison between these organizations doing research and the community that you serve. Next slide. So this is something really important because we've been talking about the different hats and different roles and activities. And which is very important to mention here is that CHWs do not replace existing care team members. The idea is to work with other team members to make sure that we address the needs of our patients, either because they live in a community where there is violence, or they are or they are in a community which is a food desert, and you need to improve access to healthy food to your patients. And the idea is to work with the whole team, and you are not replacing other care team members. So health educators have their own role, the nurse have specific roles, as well as the doctor. And the CHW has, even though we're in different hats, they serve the patient and making sure that the patient receive all the, or you cover all the healthcare needs of your patients. Next slide. So this is very important, and thank you for the diabetes self-management and education support question. This is some data from the American Association of Diabetes Educators, and it's basically saying that for every diabetes educator working in the United States, there are at least 1,000 patients living with diabetes in need of diabetes self-management, education, and support. And for every person with prediabetes seeking evidence-based care to prevent or delay the development of type 2 diabetes, there are another 5,600 who could join a lifestyle change program. So this is extremely important. There are great needs outside. You know them, you in the community know better the needs. And even though we've been talking about low income population, is not the same to be in a rural area, for instance, or when you compare patients with diabetes in rural areas and urban areas, probably the needs are a bit different. Access to care may be more difficult in rural areas, but those living in urban areas may experience some other challenges like community violence, which basically is an obstacle for them to exercise and to do some kind of outdoor activities. So this is the real challenge. And you, as I've been saying, you better than anybody else know what the challenges are in the community that you live in and the patients that you serve. Is there any comment in the chat?
Nope, not at the moment.
Okay, next slide. So based on what the Community Preventive Services Task Force recommending, the CHW can get into different kind of activities with the healthcare team, providing some basic health education on diet, physical activity, weight management. And we have highlighted the smoking cessation because this is another big need in some of the communities that we serve. And patients who smoke are more likely to have diabetes. And smoking in general put patients at risk of developing some diabetes complications as well. So smoking cessation has been a big priority in public housing, for instance, and people experiencing homelessness. So this is another area that you can keep in mind when you talk to your patients and provide some resources to smoking cessation places or where patients can get some programs. It's my understanding that some health centers offer smoking cessation, whereas other refer patients to the smoking cessation programs in the community. So keep in mind that in addition to providing interventions on dieting or physical activity or weight management, smoking cessation is another big issue for those experiencing either pre-diabetes or diabetes. Next slide. So the recommendations are on health educations, on diabetes prevention, on specifically one-on-one interactions, lifestyle modifications, either doing home visit or group sessions, and being part of the clinical care team, and the extended support to individuals at high risk for diabetes. We've been talking, or we talked last week about gestational diabetes, and those women who experience diabetes while they are pregnant are more likely to have diabetes type 2 or type 2 diabetes. So we're making sure that we provide basic information to our patients and work with your CMO, your nurses, see what kind of education you can provide to your patients. Next slide. And again, this is based on evidence-based research. This is not something that we are just inventing or getting from non-reliable reliable resources. There have been some studies where CHW have proved that they can help the clinical staff in improving health or reducing health disparities or enhancing health equity. In regards to improving health, you are patient navigators. You help patients to get insurance or medications at low cost or free or for free, and addressing housing needs, for instance, or addressing other issues like health literacy issues, and at the same time making sure that the patients have the same access to care as anybody else in the United States. Next slide. In regards to research, we've been discussing as well the research piece. There are several research that are being done right now, performed on patients with diabetes, specifically, which is diabetes control and weight management, cardiovascular factors or risk factors, behavioral change, specifically for those with diabetes, either how to make patients understand that physical activity goes or is part of the prevention for diabetes and any cardiovascular disease, as well as nutrition strategies. So if your health center has the opportunity to work with some of the organizations funded either by NIH or CDC on these topic areas, there is a big opportunity for CHWs to get involved in the research and being part of the research as well. Next slide. So why is so important to know these recommendations? Well, there are around 29 million people in the United States who have diabetes, and 1/3 of the US population has prediabetes based on the latest CDC reports. It's the 7th cause of death, and CHWs are able to provide patients with culturally appropriate information and education on diabetes prevention, lifestyle counseling, informal counseling, and social support. And based on the recommendation from CPSTF, CHWs are able to conduct home visit to ensure patients get the service they need. Next slide. So because of the time that we have for this session, I'm just going to mention some of the CHW's role in diabetes and some examples. We have the next 3 or 4 slides are areas where you can get involved based on your expertise, based on what you do, based on the needs of your health center, as well as the conversation that you have with the CMO or the clinical quality or clinical improvement director. But according to NIH and the American Academy of Family Practitioners, these are some of the CHW roles. We want to discuss a little bit about culturally appropriate education, which is an area that I am very interested in. And then and the example is to motivate and support healthy behavior change using culturally appropriate educational methods, which is really important if you serve the Hispanic population, for instance, or the Asian or some Asian population, or you are close to other minority groups. And it's really, really important to make sure that you speak the same language. And when I say you speak the same language, I'm not referring to whether you speak Spanish or any other language, but you understand the patient needs, as well as the patient needs your understands your instructions. So there has to be that synergy. There has to be that understanding. Sometimes if you don't speak English, for instance, a patient can get lost in translation, and you need to make sure that the patient is receiving the right information or is understanding the message that they get from their providers. So it is extremely important, as well as food. I mean, there are some foods that are rich in carbohydrates, for instance, that probably the patients do not know, and yet they believe that they are eating the right food. So if you have that understanding, then you can provide some other alternatives regarding nutrition to your patient, and you need to work with your nutritionist and the person who is responsible for the patient's nutrition. Next slide. Again, these are different roles. The resources on the slide will be available for all of you. But from here, I would like to mention the coaching and social support, specifically in the area where you have to motivate patients and support behavioral change. When you need to make sure that you have culturally appropriate materials and resources. We've been discussing that, or we discussed that last week, making sure that you are offering the materials that are easy to understand for the patients, because of the education of patients. Generally, materials are developed at the 5th grade level, so patients, you need to provide resources that are easy to understand, very simple sentences, so patients can have a better understanding of diabetes. And again, it's not only diabetes, it's any other chronic medical condition that they have, and you are making sure that they receive the information that they need. Next slide. In regards to advocacy, identifying community needs and resources, and I would like to briefly talk about the medical appointments, and specifically now that we are in the COVID era, and making sure that the patients are able to attend either in person or have a virtual visit. Making sure that if it's going to be a virtual visit, the patient has a very good understanding on how to communicate depending on the platform that they are using. You can help patients to set up the application, or to making sure that the patient needs know how to connect, how to log in, if they have to create an account. CHW can help in that process, as well as serving as translators or interpreters sometimes if they do not have somebody else who is a household member who can provide those services. Next slide. In regards to needs assessments, we've been discussing this, making sure that you offer the right information to the health center, what the needs are, specifically when we are linking social determinants of health, bringing that information to the health center. Housing is a big issue, and sometimes whether the patient is employed or if the patient is not employed, or so the patient is unemployed, for instance, and there is no income at all, how patient can have access to some of the resources that they need, healthcare resources, or at the same time, sometimes they have to juggle. And if they have access to food, probably they don't have access to medication. And that's the important role that CHW play, as we've been discussing early during this conversation. And these are just some example of how you can get involved in diabetes prevention. Next slide. So we're going to dedicate the last 5 minutes of this conversation to the case study. We are going back to our patient, AB, who is a retired 69-year-old man with a 5-year history of type 2 diabetes. He was diagnosed in 2013, but even before 2013, the patient had symptoms indicating hyperglycemia for 2 years. And the patient had a fasting blood glucose record indicating values of 118 up to 127. And he described this as borderline diabetes. The patient remembered past episodes of nocturia associated with large pasta meals and Italian pastries. At the time of the initial diagnosis, the patient was advised to lose weight at least 10 pounds. He was referred by a nurse to the health center with recent weight gain, suboptimal diabetes control, and foot pain. And he's been trying to lose weight and increase his exercise for this past 6 months without success. Next slide. So this is the assessment. This is the patient assessment. The patient at this moment, he has uncontrolled type 2 diabetes with an A1C greater than 7. And this is based on what uncontrolled diabetes is considered for patients in at health centers, clinics, or sites. It's my understanding that we are using greater than 9. But for this exercise, the patient has an A1C greater than 7 and is considered that the patient has uncontrolled diabetes, is considered obese with an BMI of 32.4. The patient has hyperlipidemia, peripheral neuropathy, hypertension, microalbumin levels in urine, and the patient and the self-care management or lifestyle deficits for these patients are limited exercise, high carbohydrate intake, and he's not part of the self-management, any self-management program. So there is a poor understanding of diabetes. Next slide. So let's briefly discuss this patient. The very first question, and again, you can either type your question in the chat or unmute yourself and just give us some feedback on what you would do for this patient. The first question is, how would you address the patient's food understanding of diabetes? What as a CHW you would do when you have to talk to the patient about diabetes in general and what they need to do, you know, or making sure that they understand diabetes, making sure that the patient understands you and understand what diabetes is. So let's wait for a few seconds to see whether we can get some feedback. You can also chime in on the other three questions that we have left. How would you help your patient with his obesity and hypertension problems? What community and education resources would you recommend to your patient? And what sociodemographic factors would you explore in your patient in addition to the ones that we just mentioned?
All right. So we received one response by Jennifer Martinez. And she says, ask patient how long they've had diabetes for and what they know about diabetes, and ask in our needs assessment any questions that they have about their care if they would like a nurse to talk to them further.
Thank you, Jenny. That's a great feedback, and you're totally right. We need to make sure that the patient really understands diabetes. We said that the patient has pre-diabetes in the beginning when the first assessment was conducted, and the patient couldn't explain specifically the diabetes or the pre-diabetes piece. Then the patient went to the next stage, and basically the patient developed diabetes. So we need to make sure that the patient has a good understanding of what diabetes is in order for him to understand the recommendation that he's going to get from the healthcare team.
Okay. All right. And then also Jennifer, she added also what way would they like to receive information, since some patients might not be able to read as well.
That's an excellent comment, Jenny, as well. Recently, we conducted another learning collaborative with another group, and we were discussing some resources. And in addition to fact sheets and in addition to infographics, some agencies have developed videos for the Hispanic population, for instance, and for other populations. They have developed, NIH has developed soap operas or brief soap operas or fotonovelas, which basically they address what diabetes is, what are some of the complications, and how family or relatives can help these patients to address the disease. So either anything that is visual, is extremely important, especially if the patient cannot read, as Jenny mentioned.
Mm-hmm. All right, and we have another response also by Lynn Olmsted. She said, summarize the education information in a simple format, refer to the diabetic support group, and also where would I find those diabetic Spanish soap operas?
Oh, that's a great question. I will give you the links that we developed for the previous learning collaborative with the training and technical assistant partners, the HRSA technical and training assistant partners, and we have links to some of the soap operas in English and Spanish, and other visual diabetes resources for patients who either have low literacy or cannot read at all.
Mm-hmm.
Thank you for that question. That's an excellent question.
Yeah. And then we have one last comment also by Belliana Watts McKilbury, saying, ask the person with diabetes if they have any questions about care and if it is okay to refer to for more instruction. Refer to the SMES program, medical nutrition therapy by the registered dietitian, exercise facilities, other services person may need, and SDOH questions. And she's also asking, could I have access to the soap operas too?
Definitely. We are going to share the soap opera links with all attendees. And in regards to the diabetes self-management, education and support, and exercise facilities, that's something that we have to coordinate with the diabetes care team. And based on the resources that you have in place, you can refer patients to other community resources. There is something that we heard from some of the health centers that we've been working with. One is and somebody mentioned here, the food prescription program, which is an extremely great idea and some of the best practices that other organizations are trying to implement, as well as there is a health center located in Arizona and they have some agreements with the park police, and they basically take patients and provide transportation to patients to national parks where patients can exercise and just walk around and have conversation with them. So anything that you can provide for patients to either improve their nutrition or get them into a exercise program work, if from a federal perspective, a national perspective, or a community perspective. So that's excellent. So it's over. It's 2:04 already. Next slide. I want to be very respectful of your time. Next session is going to be next Monday. This is the registration link, so you can access the information. We are making sure that you receive the soap opera links and everything else for your patients. Next slide. And this is our contact information. If you have any questions, you can either contact Fide, who's been our moderator for today's session, or you can contact me, and you can see our email addresses. You can also contact any of our staff as well, and you can talk to us, directly. Call us. Phone number is 703-812-8822. So thank you so much for your time, and see you next week.
Thank you all. Have a good day.